I can, it's moving for me. There you go. Look at that, Jamel.
Hey, you're a smart guy.
I don't know about that. I don't know that this is I think we need to get out of the Zoom world. I think if I was in San Antonio and we were having a glass of wine together, by the way,
I'll buy.
It would be far more enjoyable.
Do you want to take control and go back on video? And then you can address the group when we broadcast.
So I'm going to have you stop sharing your screen for right now, because when I start, I'm going to go do your introduction and all that.
Stop sharing right there.
How do I
host? You should be.
You're on now.
Where am I on?
You're on.
I like your library. I haven't been. You never invited me to your house before.
It's a construction project at this moment, but I have lots of interesting things in here.
You're on.
Looks pretty nice.
I can only see me in the small one.
Yeah.
So
how do I make me big?
You're big now. You're good.
Go ahead. You're big on this end.
Okay.
So
what's gallery view?
And how big a group are we expecting, you guys?
I'm thinking probably 30.
I was just telling us that we're
That'd be a nice group.
in 21 right now. So let's go ahead and broadcast.
So Brian, I'll need to hit share screen when I talk.
Oh, I guess we are broadcasting.
If I don't have slides.
We're broadcasting on that.
We're already broadcasting now. Okay, we've got 21 participants.
They can see you.
Okay. We're going to give us about 5 minutes before we actually start the talk. Nice. All right, there we go.
Do you want to see it like this? That's what you can see.
Okay, that's good. So right now we've got 22 online plus us.
Awesome. I see it's increasing.
Yeah.
Yeah, actually, it's good to see that. Unless you called in on 4 different computers.
No, we did not. Although I asked my son to ask all his friends to log in just to make it look good. We get a lot of computer science questions that way.
So, because you wanted some COVID positive patients, right?
Want to start? Yeah. Okay. All right, I'm going to get us started here. Well, welcome everybody. As you know, I'm Jamil Malik. I'm the president of the San Antonio Interventional Forum. And today we are trying our first Zoom meeting. I hope everybody has good audio right now. And if you have any questions, text myself or Brian Haynes, and we'll try to troubleshoot with you from my end. Dr. Tim Henry is an old friend of mine, and it's probably the easiest way to introduce him. He's an absolutely prolific physician who I met in Minneapolis back in 2003. Tim is currently at Christ Hospital in Cincinnati and is the Leidner Chair of Cardiology there after serving as the Chief of Cardiology at Cedars-Sinai for many years. And prior to that, he was at Abbott Northwest, Minneapolis Heart Institute in Minnesota. Tim's offered over 350 manuscripts. He has been a prolific researcher, has the energy of a 3-year-old, where I don't know he gets that, and has always been somebody who picks up the phone when I call. Tim was recently elected to be the incoming president of SCAI. He was also directed to kind of manage our SCAI response to COVID, and because of that, and what we're all seeing, I asked him to give us some advice about what the current state of the art care for STEMI patients and for non-STEMI patients and cardiology in general in the setting of COVID. So with that, I'm going to turn this over to Dr. Henry. If you want to start sharing your screen.
Yep. So, hey, welcome everybody, and give me a second to get this going. I think, can everybody see it? Hopefully, is it working there?
Yeah, it's working on my end.
So, first of all, I'm delighted to be here, and what I want to do is, I'm going to spend maybe 15 minutes on what I think are some important data. Many of you know much of this. But I want to use it for discussion points. And then I want to take time so that we have plenty of time to discuss real life issues. So, and I'll tell you the two things about this that I'll start with now and I'll end with. So number one, I think that this is an incredible area where SCI has taken leadership, and it's been really important for, and I think from an interventional cardiologist around the country, it really is SCI is who represents us. And so number one, I'll put a plea out for everyone. If you're not SCI members, become a SCI member. You can make a difference, and it really, really, really matters. Second of all, I'm going to describe the North American COVID myocardial infarction registry. And I would really love, I know unfortunately San Antonio is a little bit of a hot spot now. And so we'll hear about that. But we have a registry with the Canadian Interventional Society, with the American College of Cardiology Interventional Council, and with SCI to look specifically at COVID positive or suspected patients that have ST elevation. And it's a really important issue. I'm sure that many of you have already been faced with it. And so we've made it super easy. We have a central IRB. The forms are not complicated. You know, each hospital probably has 3 to 10 of these patients. No hospital has 100. So what we need is a lot of people to participate. So at the end, I'm going to really encourage everybody, if you've had some COVID positive patients with ST elevation, join NACME, put them in. We'll do everything possible to get it, because we need this response for the world, and we're going to come back to that. So with that being said, this is kind of the outline I want to talk about, because I think there's lots of aspects with COVID. To give you also an issue, I think that in Ohio, we have a moderate response. But what I've really had the opportunity to do is talk to people all around the United States almost every day. So I feel really good from the standpoint of, and that includes Dr. Malik. We've had conversations already about general and specific issues in San Antonio. And so I think that's been helpful for me, because this is a disease that varies a lot geographically, but I think when you get a broader experience, it gives you some insight. And I think it's also a complicated disease. I'll start off by saying it's unfortunate that politics become involved in this, and we should try to avoid that. We should look at this from a health perspective, and this is a public health problem, and we need to see how to deal it. And you know what? Everybody's made mistakes, and it shouldn't matter what people did yesterday. What should matter is what we do today. So the background of this is the virus itself. It kind of looks pretty, right? Like, this is what's destroyed the world, or certainly disrupted the world. How about that? And this is the structure of the coronavirus. And there's lots of coronaviruses. And I will tell you that we are learning more every day, including there's probably cross-reactivity, so that a fair number of people are actually, who've had other coronaviruses, are probably less susceptible. But again, we're learning, and I'm sure 6 months from now, we'll know a lot more than we know now. Another really important issue about the coronavirus is that it gets into the cell through the angiotensin converting enzyme 2 receptor. And that's important because when you look at the manifestations of COVID-19, it has to do with where it gets into the cell. And it really is very prominent in endothelial cells. And so you notice this is part of the manifestations of that. Okay, When you look at the symptoms, one of the problems with it is symptoms are broad, from asymptomatic. So when you take 20-year-olds, probably 70% are asymptomatic. And then as you get older, the number of asymptomatic people go down. But there are people that have a wide, initially it was all felt to be shortness of breath and cough, and fever. Well, we now know there's definitely people without fever. There's definitely people with primary GI complaints. There's a wide spectrum, and they're listed here. But importantly, 10 to 35% of people have abnormal troponin on admission. So this is patients admitted to the hospital. And that's a really important point. And we're going to come back to that. Now, when you look at this, when you look at the markers, patients have increased CRP, they have increased BNP, troponin, and D-dimer, I would say, are probably the two most important, because D-dimer clearly appears to predict the people that have the thrombotic complications. And then troponin is, I'm going to show you, is very predictive in terms of adverse outcomes. And does that matter? Absolutely, it matters. I'll tell you, because the other issue that we've had, we've gotten so much better at treating it. And I'll tell you, even though when you look at Ohio that there's been a bump, we have not intubated someone for 7 weeks. And in the last 6 weeks, we've had one death, and that was a hospice patient. So we're a lot better at treating it, and that involves troponin, and I'm going to come back to that in a minute. So, oops, sorry, wrong way. So when you look at it, when you look at COVID, there's another issue about cardiovascular disease, and that's patients with a history of coronary vascular disease, patients with a history of diabetes, and people with a history of hypertension. Now, hypertension is probably just because most of the people in the population have hypertension. But listen, cardiovascular disease, especially decreased function, and diabetes, weight are really important. And then, as I'm sure you know, in San Antonio, it's interesting because this is a longer story over wine, but 3 months ago, before we knew all this, it was very clear that Hispanic males are at higher risk. And the data set that we had more than 3 months ago, before this was all became clear, was that Hispanic males had a risk ratio of about almost 7 times what a white, and Asians were actually lower, and then blacks were about 3, but the two highest were Hispanics and Native Americans. And it's not all Native Americans, by the way. It's interesting. In particular, Navajos have been tremendously affected. And so there's a lot of genetic predisposition about this that we're going to learn more about. But clearly, cardiovascular disease is a risk and age is a risk. So this is a really important slide. These are hospitalized patients. And if you had a combination of coronary disease, and I think all of those rates are too high now, but they point out a really important thing. If you're admitted and you have a history of cardiovascular disease and you have an elevated troponin, you had a 70% mortality. I know that's way too high now. The second line down was, and I'm not sure if I can show that or not, but you can see the second line. Can you see the arrow?
Yep. Yeah,
so
good.
The second line is troponin without coronary disease. Third line is coronary disease without troponin, and then the bottom line is neither. But you can see how predictive an elevated troponin on admission is. So I would encourage everybody who's in it. It also varies from hospital to hospital on who admits these patients. Sometimes it's ICU, sometimes it's pulmonary, sometimes it's ID. I would encourage everybody that they measure a troponin and a D-dimer on everyone. I would do BNP as well. But I think it's really incredibly predictive, and I'll come back even more. So what about the cardiovascular manifestations? So if you look at this, it's very broad. So number one, why do people get elevated troponin? So number one, there's a type 2, which is just a oxygen supply demand. Patients are hypoxic and tachycardic and febrile, especially if they have underlying coronary disease. Number 2, just like with influenza, people can have plaque rupture. So there's this increase in plaque rupture. Number 3, you have myocarditis on the top. So if you look up here, there's a direct, and we'll talk more about that, but that's clearly true. Next, you have this issue of microvascular dysfunction and kind of in the prothrombotic thing. There's also, obviously, there's a tremendous amount of stress in the world right now, and there's been a clear increase in stress cardiomyopathy. And then the last is kind of hyperinflammatory state. So there's lots of ranges that you, and I'm sure most of you have seen the whole spectrum of this. So when you come in, you have people that have ST elevation, and I'm going to specifically focus on that. You also can have injury without ST elevation, which is just the positive troponin. You also have, there's patients with arrhythmias, patients have come in with a heart failure and cardiogenic shock, and that can be both from COVID itself or the consequences of will come back. There's some isolated people that have had pericardial fusions and tamponade, kind of like this extensive myocarditis. And then there's the thrombotic complication.
Hey, so I got, this one's a tricky one.
Can you hear me okay?
Yeah, go ahead.
All right. So this is actually the thrombotic complications. And this is a really important point because as you see from uninfected to asymptomatic, you can see this increase in prothrombotic issues. And I think it's pretty standard of care now that patients who have even mild infections and certainly moderate severe patients should be on prophylaxis. So whether you use sub-Q heparin or whether you use a NOAC, there's been a dispute on what to do. But I clearly think that people should use standard venous thromboembolism prophylaxis, just like we would with bedridden patients or post-orthopedic patients. And I do think that this is a life-saving measure. And so do not neglect this. Next, I'm going to talk about STEMI in COVID. So this is a really interesting thing, and I'll tell you a really interesting story about this. So this came from online, and patients said that they were having a decrease in STEMI activation. So we actually tested it. So many of you may know, but I've been involved in STEMI networks for a long time, had a large network in Minnesota, did the same thing in Los Angeles at Cedars and now at Christ Hospital. So we took 9 large STEMI systems in the United States, and we took March data. And this is a great story because by April 1st, I had March data from 7 different hospitals. By April 2nd, I had data from 9, the 9 that we used, and we wanted to get high prevalence area and low prevalence area. We submitted it to JAC on April 3rd, and on April 6th, it was published. Like, it's amazing. That's probably never happened to any of us in the country. This paper now has been cited over 300 times already. And it's clearly true. What has been reproduced in Spain, in Italy, in France, this marked reduction. And at the time that we did this in March, all 9 STEMI systems had a reduction, whether there was high prevalence or not. And this is an issue, like, why does this happen? Some people think because there's less pollution. Okay, maybe that counts for 1 out of a million. But most of this is because we scared the crap out of people. And we literally scared people to death. And I'm going to show you data to support that. So this was true. If you look at it, this is actually incidence of hospitalization that comes in Northern California. You see the same thing in terms of as COVID went up and we had the shelter in place in the middle of March, you saw this significant reduction in hospitalization for acute MI. This is actually similar data. This actually comes from New England and in Massachusetts. And it shows, this is a little broader. It shows that the reduction for chest pain, the reduction for heart failure, reduction for stroke, and the reduction for all cardiovascular illnesses went down. At the same time, COVID went up, and for a reference, you can see the top line. So this was a dramatic reduction in cardiovascular disease that we saw across the world, okay? And we're gonna come back to it. The second thing that we got from social media is lots of people started putting these cases online that showed that they had ST elevation, and then when we took them to the cath lab, that they had normal coronaries. So we still, and this is why I'm going to get everyone to join NACME, we still don't know exactly what the prevalence is. My guess is that this is probably 20 to 30%. And the second thing is, I don't think you can tell the difference. So it's a really important point. You might sometimes be able to tell the combination of the EKG and a handheld ultrasound, you might be able to show, but I'm going to recommend that people, we also, at the beginning, we didn't know that it's safe. We now know it's safe to take these people to cath lab, and the official recommendations would be, if you have ischemic symptoms, which includes shortness of breath and chest pain, and you have ST elevation, you should go to the cath lab. And number one, you make a diagnosis. Number two, a large percentage of these people will have true STEMIs that need to be fixed. Whether or not they're the prothrombotic type, we'll talk about that because I think they're two different. And then number three, you can also take better care of them. So whether they need a Swan Ganz or they need hemodynamic support, you can do it. So I think ischemic symptoms, ST elevation, we should take them to the cath lab just like we do every place else, and do it safely with proper PPE. I personally use an N95 mask. I don't even use a face mask, but we put a mask on the patient. You obviously have radiation between them. Whether you're radio or femoral, you're 5 feet away. And I don't know personally anybody that caught it, that any interventional cardiologist that got it in the hospital or got it in the cath lab. And we've talked to a ton of people. So I think it's safe to do, and I think it's the best care to do. And this is a good example of this. I really don't, I think it's really difficult, having looked at a lot of these EKGs, to know whether you have myocarditis or you have a myocardial infarction. Just like I think you can't tell between Takasubus and a myocardial infarction. And so again, best care is to do that. Now, what about the data on this? So this is actually the first paper from the New England Journal that had 18 patients. Now, interesting, 9 of these 18 patients didn't even have an angiogram. And about half of them developed the ST elevation in the hospital. And when they did cath them, about half of them had normal coronaries. So it's a little, it's the first one, it's in the New England Journal, but this is 3. And you can see that in the 3 different studies, one from Italy, one from France, and one from New York, there's variability in terms of how they defined it. First of all, these are all COVID positive patients, but some of them are presumed by either chest X-ray or chest CT. You can see mortality ranges from 18% to 72%. That's a pretty wide range. And likewise, the percent of obstructive disease versus non-obstructive disease was variable. So the France one, almost all had obstructive disease. The Italy and New York one, it was about 65 to 70%. So certainly in COVID, plenty of people that have obstructive disease that need it fixed. Now, the next thing, so then this is about NACME. And I think it's really important. So this is a North American COVID myocardial infarction registry. So one really super important part about this is an incredible cooperation between the US, the Canadian Society, US meaning SCI, the Canadian Society, as well as American College of Cardiology. So we work together very closely on this. The trial design paper has been published. We now have over 250 patients that are enrolled, but we need more. And I would really, really love to have some San Antonio sites in this. So please, and we will make it simple for you, I promise. It's a relatively straightforward form. have a fellow, have a junior faculty, have your STEMI coordinator. It's not complicated, and we need the patients. We really need to have a true experience of what these are. So what our goal was to get who gets in? Anybody who is COVID positive or suspected. So when you went to the cath lab, if you suspected they had COVID, that's fine. We want a broad registry because if you subsequently are turned out to be negative, we're going to use that patient as a control group. And then the second thing we're going to do as a control group that we're going to do propensity scoring and get a matched thing is what's called the Midwest STEMI Consortium. So this is a combination of Minneapolis Heart, where I started the registry, and Jamil was actually a part, put a bunch of those patients in actually. And then number two, Prairie Cardiovascular in Illinois, Iowa Heart in Des Moines, and Christ Hospital in Cincinnati. And we have more than 15,000 consecutive patients. And what we do in this registry, anybody with a STEMI activation. So if you die on your way to the cath lab, you're still in the registry. If you're 105 years old, you're in the registry. If you have stress cardiomyopathy, if you have SCAD, it doesn't matter. Any STEMI activation, and there's no exclusions. So that's perfect because what we want is, like cath PCI, people say, why not cath PCI? Cath PCI only puts people in that get PCI. So a lot of these patients that are COVID positive would get excluded. And so we want that, and we want to use it so that we can actually get I'm sure that we're going to have questions on how to treat these people. And we don't know all the answers right now. And the only way to do it is to actually get data. So this is an example. First patient came in, had successful PCI, but then subsequently ruled out. That's okay, put them in the registry. Patient number two came in, had ST elevation, was confirmed COVID, but was too sick, was intubated. They elected and put that patient in because we want to know the outcomes of who gets cathed and who doesn't get cathed. Patient number three had the diagnosis of MI, got a lytic agent. I don't recommend that, and we'll talk about that, but they still get in the registry. We want anybody that's COVID positive or suspected and ST elevation. All right, next thing I'm going to talk about is this, and that's, in some states, the cure has been worse than the disease. And I'll say that, and that's the unintended consequences of COVID, because this deals with this from a cardiovascular standpoint is very important. So when we had to stay at home, what you saw when they announced to stay at home in the middle of March, there was a 40% reduction in STEMI activations. Their ERs all across the country had an overall drop in business between 40 and 70%. So patients were not going to the emergency room. And we know all over the world this was true. COVID, high prevalence or low prevalence, it was true. And what we saw was we started seeing people come in with late complications of MI. It was like we went back 30 years ago. It's like we have a paper that's coming out that's called Back to the Future. And and there's a special issue of JACC case reports where they were just looking at complications of late presentation. Now, this is another example of this. You can see that the number of patients that came to the emergency room, actually the screens cover me totally, but you can see in California, the decrease in patients going to the emergency department was dramatic compared to patients in a standard thing. And then this is actually data on the left. You can see over here, you see STEMI presentations went way down. Cath lab activations went way down. Referrals for PCI went way down. If you look at the second really key thing is when people did come to the hospital, they came later. So the percentage of people who came later, patients who came late, you can see went from 10% to 30%. And so this was a big problem. Did it matter? Yes. There was a significant decrease in the ejection fraction. There was a significant increase in mortality. And this is not just COVID patients, this is everybody. So it affected the care of everyone. And what we also saw is this dramatic increase in out-of-hospital cardiac arrest. Again, this is true all around the world. There's data from New York, there's data from France, there's data from Spain that you saw with COVID compared to a year ago, 2019. Look at the dramatic increase in out-of-hospital cardiac arrest. More importantly, there was a dramatic increase in dead on arrival. So not just who you did things, but when you went to the house and the patient was already dead. Now, are some of those due to COVID? There's some, but arrhythmias is not a common problem with COVID. Most of the patients come to the hospital with shortness of breath. And this, we think that most of this is related to cardiovascular complications, not just MI, but aortic dissections, stroke. We had 6 patients on our TAVR list that died at home. And 4 of them, we pleaded with the patient and the family to come to the hospital, and they wouldn't come. They wouldn't come and get their procedure. So this issue of the unintended consequences is a really important issue, and we're going to come back to it. This is actually data from Italy that shows the same thing, a dramatic increase in out-of-hospital cardiac arrest that occurred right with the timing of increased COVID. This is in France, same thing, dramatic increase in, look at the difference, you guys. Every year it was the same. And in 2020, in the lockdown, you see this dramatic increase and a decrease in the number of people admitted alive. So this consequence of what we did with the lockdown is a really important one and hopefully a lesson learned. And then the other thing is we saw this increase in STEMI complications. So we had an increase in ventricular septal rupture, increase in free wall rupture, increase in papillary muscle rupture, increase in patients who presented with LV aneurysms from 5-day-old infarcts who came into the hospital with a stroke because they had a LV thrombus. All of these were things that really in the area of reperfusion, we had mostly treated, right? Most of these things we rarely see anymore because we treat people quickly. And then why do people refuse to come? So you know what the number one thing was? They'd worried about getting sick in the hospital. That was the number one. Number two was it would take longer to get care or hard to fit. Cost is an issue. Thing. But the number one cause was they're worried about getting to the hospital. And that's not what usually is the issue. So we have done, and I'm going to end with this, 2 things. Number one, guidelines. So I think I'm proud of this paper, actually. This was in JACC in the end of March, and it was a really good group of people. We put out management for acute myocardial infarction, and it was a consensus statement from SCI, ACC, and American College of Emergency Physicians. And it wasn't simple to get consensus, especially in March, right? Because we were learning. But this is what we said, and if you look at it, if you're probable or possible, it all comes down to the bottom. Take them to the cath lab. We know that is the best care. We know it's the best care. And it's the best care if you have COVID, and it's the best care if you don't have COVID. And so, there was this early push about giving lytics. I don't recommend it because 30 to 50% are going to have normal coronaries. And now you just gave lytics to a group of people that it might have bad consequences, and it doesn't solve the ST elevation. So again, this is I like this paper. I don't want to spend time because I want to get to questions. The very last thing is, what does SCI do? So number one, we and if you guys haven't seen this, and this was so effective in Cincinnati, because in March we saw this rapid reduction. And we did a lot of public relations on the TV, on the radio, and then Sky has a campaign that's called Second Still Count. And it's free publicity. You can put it in use it in your hospital. It's extremely well done. You just go to the Sky website and you'll get it. And in April, we had an increase back to our normal of STEMIs. In fact, we've had a little increase. And that didn't happen all over the country. The people who have actually done public relations, and you got to tell people it's safe to come to the hospital. It's safe to come to the hospital. And you have to get that message out, because we saw too many people dying from not getting the appropriate care. Second thing is, so Sky, and I think from a national standpoint, representing us very well right now in terms of coding, in terms of reimbursement. There was just a thing came out to all the your Sky members today showing that there was they wanted to do a 9% reduction in procedures for cardiology, and obviously we're strongly advocating against that. So I think Sky represents us there very well. And I will tell you that right now, ACC is extremely good at helping. And then the next is we had surveys. So number one, we have the registries. We have a mechanical circulatory support registry as well. And we did surveys for number one, trainees. So huge impact on trainees, on interventional fellows. Number one, a fair number of them lost their contracts that they already had. Number two, a fair number of them didn't get the appropriate number of cases that they had hoped to get. And then the other survey is we looked at the effect on cath lab with cath lab directors and interventional cardiologists. So Sky did a tremendous amount of work representing you. And so number one, I'll end with like I started, join Sky if you aren't already a member, number one. And then number two, be part of NACME. We need your cases. And so I'm going to stop sharing and turn it over to you guys.
I can tell you that was just spectacular, Tim, and exactly what we wanted to hear from you. We're going to move on now and save the questions till after we have the two other speakers. I'm going to turn the floor over to Dr. Tommy Pollard. And many of you know Tommy. He's a local boy. You know, he did most of his training here in San Antonio. Spent 20 years after that in Tennessee, really pioneering his the cardiothoracic program out there and doing a lot with the heart team and that. And we were very lucky that Tommy decided to come back to San Antonio after becoming an empty nester, which I know what that's like. He himself contracted COVID, and he's just going to share his personal experience about what it was like as a physician having COVID. And then following him, we're going to open it up to Chandra Kunavarapu, who's a good friend also. He runs the ECMO program at Maine Methodist. And he's going to share with you kind of, in the HCA system being the only ECMO program, what ECMO has looked like in the setting of COVID and kind of what he's seeing and what he would ask us as referring physicians to do. So with that, I'm going to turn it over to Dr. Pollard. If you want to start sharing your screen, sir.
All right, can you see me?
He doesn't need to share screen.
Oh, you don't need to share. You don't need to share screen. I'm sorry. They should all be able to see you if you're talking.
Yeah. So
how do I enlarge him?
there you go.
All right, now you're up. Good, go for it.
Okay. Well, again, I want to thank Dr. Malik and Brian from Medtronic for inviting me to be here. I really have enjoyed the SAFE meeting since I've been back, and I really miss meeting in person, the steak and the cocktails as well. Although I will say my wife made me a very nice mezcal margarita here, which I'll be happy to share the recipe next time we all get together. Again, I guess I'm fortunate that I don't have a really exciting story to tell. I was pretty fortunate in my experience with COVID. It kind of all started one Friday when we had a lot of cases. We were operating late at night in retrospect, one of my techs told me that he noticed I started kind of coughing toward the end of the last case. When I went home that night, I noticed the cough. I took my temperature and it was 99.6. So it was kind of on my radar that something was wrong. But the next morning, I really felt feverish. Temperature was 100.9. So I became worried at that point, called our medical director, went to our ER, got a rapid test, which was within a couple hours, I knew I was positive. I live in a condo here in downtown San Antonio. My wife and I already had kind of talked about what we would do if this happened. And so, you know, this is actually my first Zoom meeting. I need to get one of those fancy backgrounds, but the background you see here was my jail cell for 2 weeks while I was kind of locked in the spare bedroom of our condo. My wife would just kind of leave food at the door. And when she'd get mad at me, she wouldn't leave as much. But I was very fortunate that really that first morning, fever and chills, but after that, you know, took a nap and really felt better, and there was really, you know, really had kind of a mild experience. I got all the typical things in the sense that I did have a dry cough that persisted for, you know, really about 3 or 4 weeks, really, even after I was out of quarantine. I had nasal congestion and kind of a metallic taste that wouldn't go away. I did lose taste to food, and for about a week, I was worried if that would come back, but eventually did. My wife gave me all the cheap wine during that time to get it out of the cupboard, I think. But really kind of had a pretty mild experience, and did 2 weeks of quarantine. After that was over, I kind of just took a week off and then was able to go back to work within 3 weeks. I did not retest. I was kind of discouraged about doing that, thinking there might be a false positive. During my quarantine, I didn't really do any therapeutics other than I did not take hydroxychloroquine. I did take azithromycin during that time, took high doses of vitamin D. Didn't do any antithrombotic meds, although again, when you're kind of locked up, I was concerned about getting a DVT or something. So yeah, I bought a Peloton during that time. I kind of jumped on that, learned how to do yoga. I can get my foot behind my head now, but I'm not going to show you that. So just try to keep myself entertained for a couple of weeks. And I was fortunate, again, no long-lasting effects that I'm aware of. So.
Well, thank you for sharing your experience. And I wanted to bring you on simply because, you know, being part of the cardiovascular community in San Antonio, this affects all of us on a daily basis. We're all treating COVID patients. We don't know who's positive. We don't know who's negative most of the time. We got to take precautions for ourselves. I mean, I know that many of you are friends with Dr. Barbaro. He's doing much better now. And, you know, we're all praying for him as he recovers. It has affected us personally as well as professionally across the spectrum. And to that, I would like to turn this over now to Chandra Kunavarapu, who is part of the heart failure transplant team and is really running the ECMO, is spearheading ECMO in COVID in San Antonio. So Chandra, if you want to take it from there.
Can you hear me?
Yes, perfectly.
Great. Yeah, thank you, Jamil and Brian, for inviting me. And it's really a humbling experience for us. And I first want to acknowledge the whole team, and more importantly, my partner, Dr. Delavope, who's online, who's part of this team. He's a co-director of the ECMO program. And then we have Mike Kwan, who was also actively involved. And we had unbelievable experience seeing sickest of the sick in our COVID unit. I unfortunately, you know, the talk I'm going to present would be on more respiratory failure than cardiac or interventional cases. So bear with me. You know, some of this could be boring and over the head, but I truly want to share my experience. And it, like I said, you know, since we see the sickest, I want to present the sickest patient. I know majority, 90% of the patients do well. And thankfully, Dr. Paula did very well. And that's what we see routinely. But I want to take you to the other side of the spectrum where where we see unbelievable manifestations of this unprecedented disease process. So Brian, if you can help me project some slides and scroll through this, I'll appreciate it.
We're getting there. Just give me a second.
No problem. Yeah. So here at Methodist, so far we have done close to, I would say, 60 VV or 58 VV ECMOs, I would say. And this happened over the last 3 to 4 month period. We became a hub.
Andrew, stand by for 1 second.
Sure, go ahead.
I haven't shared the screen yet.
Okay, that's fine.
Share screen.
Wow, 60.
Yep, let's go on here.
Okay, we're on the beginning slide now. Go ahead.
Okay,
just
go ahead. Go to the next one. So I'm going to start off with a simple case, a complex case. You know, we had a lot of good cases, but this it's not fun to show a case which quickly got better. So I'm going to go make you go, just see how a patient progresses and how bad it gets, despite us doing what we can on an ECMO patient. This is the first only case I'm going to talk, and I'm just going to then go and show you all what we have done without data and all that stuff. But to start off, this is a 50-year-old male, Hispanic male, a police officer. Only had a history of hypertension. He was on an ARB. And this is important. We have seen a lot of hypertension Hispanic males in our COVID unit. And hypertension and diabetes seems to be one of the common risk factors we are seeing in our ICU. Anyway, he stayed at home. He rapidly deteriorated. He was diagnosed with COVID 2 days prior to presentation to the emergency room. He presented with cough, fever, and shortness of breath. On arrival, his heart rate was 120. He was breathing at 44 breaths per minute. His blood pressure was normal. His saturation, this is true. His saturation, actually, your physicians told us his saturation was 36% on room air. He placed him on 100% non-rebreather, high-flow nasal cannula. That's the blood gas you guys are seeing. The PaO2 is 44.7 with a saturation of 82%. Well, I didn't update some of the inflammatory markers. I'm sorry, I've made this presentation last minute. But his D-dimer was 5, his CRP was 180, ferritin was close to 1500, I think, at the time of admission. His echo showed moderate RV dysfunction and moderate RV enlargement, which is common in this extreme hypoxic respiratory failure patient. So we took a different stance here at Methodist. We decided to go on ECMO early, and I'll tell you why. In future slides. So we placed him on VV ECMO at the bedside in the unit while he was awake. And you can see the post-ABG ECMO, post-ECMO ABG. He was on 2 liters of nasal cannula from 100% non-rebreather. And his PaO2 was only 52 with a saturation of 88%. This was on full ECMO support. Next slide, Brian. That's his presentation chest imaging. The chest X-ray or CT chest, you can see there, it's diffuse, it shows diffuse infiltrates, ground glass appearance. Think about this, his symptoms started 5 days ago, and within 5 days, his chest X-ray looked like this with a saturation of 50%. So a rapid deterioration in this patient, which is very common in some of these patients. Next slide. So his hospital course, was not smooth at all. That's why I picked his case. He slowly deteriorated despite being on peripheral VV ECMO, which we did through femoral cannulation. He required, on a daily basis, higher oxygen requirement. He ended up on 15, 20, 30 liters of high flow nasal cannula oxygen support, and remained profoundly hypoxic. So on day 12, we had to intubate him, and we decided to change out his cannulas because he's been lying in bed, sitting up occasionally with femoral cannulas. So we decided to go subclavian route, and this is we probably have done 50 of these in last 2 years, I would say 50 or 60. But if you can play the video, Brian. As you see here, this is a Medtronic Crescent cannula. It's a multi-lumen cannula. It has drain ports all the way from distal end to the SVC sides. So it has 3 drain ports, and then there is 1 return port, which we like to place right near the tricuspid valve. So if we can freeze it, it's hard for me to freeze from my end, but on the fluoroscopy, right there, come up a little bit.
Just tell me where you want me to stop.
Come up, keep running it. Keep going. Right there, stop it right there. So you see those 2 dark markings there, right there, yes. So that's the exit port, that's the outlet. And we like to place that outlet right in the mid-right atrium and direct that blood flow towards the tricuspid valve. And I'll show you an echo of this patient, which confirms that finding. Next slide. But this is a 30 French cannula, which is placed through the subclavian route. Usually we go from the left side. You know, what this does is this allows us to move the patient, help the patient ambulate, and also help us to extubate, take out the sedative drugs and all that stuff, and wait on that lung to recover. And this is something unique we started doing for last 2 years, 2.5 years now. And we gained a lot of experience. The complications rates are not significantly high at all. Mike, Dr. Kwan, Dr. Delavope, myself, we all do that here. Next slide. So this is the echo actually showing how that outlet sends the blood flow towards the right ventricle. As you see here, I guess most of you can identify this. There are 2 color jets coming out there. One is the tricuspid regurg. The other one is the color going towards the right ventricle. And that's the flow from the subclavian cannula going into the right ventricle. And on the right side, there is a still image with an arrow, if you can see it. And I'm showing you the direction of the blood flow towards the right ventricle. So when we put these cannulas in, we make every effort to make sure that outlet is facing the tricuspid annulus and tricuspid valve. So we know that oxygenated blood is going towards the pulmonary artery. Next slide. So this guy underwent this cannulation, and as you see there, his hospital course was very rocky. The treatment options are limited, as most of you are aware. We initially started treating everyone with Plaquenil and steroids. We decided later to stop using hydrochloroquine. Nowadays, we're using remdesivir convalescent plasma routinely and dexamethasone 6 milligrams a day for 7 to 10 days. But this patient got Plaquenil, remdesivir, convalescent plasma, and also completed steroid treatment. He unfortunately got re-intubated on day 17, underwent a tracheostomy on day 20, and he went through routine complicated courses when someone stays on ECMO for too long. He had some bacteremia. He developed recurrent right and left tension pneumothoraces. Our intensivist did an excellent job in putting chest tubes and optimizing him. Unfortunately, he never recovered. And that's something we see in our unit because we get all these end-stage patients who are crashing, who stay at home too long, get exposed to the cytokine syndrome, don't get treatment, come in late. When they come in late, the lung is already in that last phase of disease process, we believe, where sometimes the lung doesn't recover and the lung develops a fibrotic phase where there is no recovery anymore. And unfortunately, he went to that phase. He developed persistent respiratory failure. He was on trach. He was on high ECMO sweep. We couldn't wean him off. But he was awake. He had normal renal function. His blood pressure was normal. I showed you the echocardiogram. His right ventricle wasn't that bad. He was ambulating 100 feet. He was talking to his family. He was eating. So we decided to go with the lung transplant evaluation on him. Next page. So that's the chest X-ray day 79 since he came to our hospital. This is day 79 chest X-ray. This is how the lung looks once it's fibrotic, I guess. You see 2 pigtail catheters, both on left and right. He barely has some aeration there. He has a tracheostomy in his, up in his chest. No real lung. So this is when we decided to transfer him to a lung transplant program. Next slide. This is day 99. He got a lung transplant and he's alive. He's doing well. So this is a good story. I picked up this case because, again, it's not always smooth. These guys do well sometimes. 50% of them don't do well. The question is, what do we do when we go in with this expensive therapy? How do we exit these guys if the lung doesn't recover? Fortunately, this patient had an opportunity. He got a lung transplant and he's alive. He's doing well. He's discharged home. Next slide. So the reason ECMO came into our management option is because, one, we've been doing ECMOs for the last 6 years. We have done close to 200 ECMOs last year. So we felt comfortable being aggressive in our institution. But initially when COVID came on, we said no ECMOs to COVID patients for all the right reasons, because you want to take care of your routine patient in your hospital. You don't want to go with this multidisciplinary, time-intense therapy when you really don't know what a patient is going to behave like. But we had some experiences initially when we decided to place patients on ECMO. The patients did well. So and then we had data coming out of Italy and New York City, as most of you are aware of, that ventilator-associated mortality is close to 85%. It's obviously age-dependent, but once someone develops ARDS and severe hypoxic respiratory failure, the mortality is significantly high. VV ECMO, as most of you know, has a mortality of 50%. But how do you come in with an ECMO? How do you play it when there is a ongoing ventilator-associated lung injury in these rapidly deteriorating high-risk COVID patients is a tough decision to make. So what we said was we'll go in early because we want to avoid ventilator-associated barotrauma and see if just providing oxygenation would help these patients recover somehow. But we also understood that ECMO can increase other complications like bleeding, infections, right heart failure, more importantly. And also it's expensive, it's time intensive. It requires multidisciplinary staff. So we are aware of all that and we decided to go this route, and I'll show you how we did it. Next slide. So this is how we did it. We said we were very strict with our inclusion criteria, even though we said say 18 to 70 years of age. We did not pick, our patients were within 20 to 40 years of age, majority of the time. All the patients had a PF ratio of less than 100. PF ratio of less than 100 implies that the PaO2 is less than 60 on 100% of FiO2 in our patient population. So that's pretty hypoxic respiratory failure. And obviously chest X-ray should show bilateral infiltrates. And we excluded patients who had renal failure, who were on mechanical ventilation more than 7 to 10 days, and who are on more than 2 presses, or even if they're more than 1, we declined them. And we chose a multidisciplinary selection team. This team included 3 intensivists, 2 cardiologists, an ID physician, nephrologist, as the CMO, CNO, the bed control team, perfusionist, and a nursing manager. And this was important for us because we didn't want to go into this without taking care of the routine patients in our institution or our sister hospitals. And we kept the bed management very simple with our experience we had in last several years. We have a robust education team, which is chaired by Dr. Della Volpe. We constantly train ECMO specialists. So we have a lot of nurses who are specialized in managing ECMO. We decided to go with one-on-one nursing with 1 to 4 ECMO specialists overseeing these ECMO patients. We had 1 perfusionist sitting in the unit. We cannulated the patients at the bedside in the ICU with the X-ray. We didn't take the patients to the cath lab unless we exchanged them to subclavian route. We had 24-hour intensivists in the unit. We had physical therapy team involved, and also palliative care team and a lung transplant evaluation if needed. Next slide. So I did some statistical analysis on our patient population. I don't have all the patients in this analysis, but I just wanted to show you certain trends here. As you look at these variables, demographics, and remember these are the referrals coming from different hospitals from south side of Texas. As you see there, majority are male, 67% are male. Very important to know. Hispanic, 61%. We have very high BMI in our patient population. Mean BMI is 32. Now, we compared survived versus non-survival. As you see there, there's no big difference. And again, this is a small sample, so I'm not going to make a big deal about this slide, but I want to show you that majority of these patients in our community are they have either hypertension, diabetes, asthma, and mostly are males. Next slide. And inflammatory variables. This is something Dr. Henry pointed out a little bit. This is a very interesting pathology which happens in COVID pneumonia. This acute cytokine storm which happens creates microthrombi, occludes peripheral capillaries, and the patients cannot extract oxygen. The VQ matching is so poor. Despite how much oxygen you dump in them, they cannot extract it. And I think that starts off because of this cytokine response, which happens when the patient gets infected with COVID. The patients who survived are the ones who had less procal, less D-dimer on presentation, or less CRP levels. So that's an interesting observation we found in our patient population. Again, it's very hard to pick the right patient to put on ECMO. All these patients are very sick. Our criteria is simple. We said age, younger patients with with severely hypoxic respiratory failure. But other than that, it's really hard to pick and choose, I think. But if you look at our data retrospectively, we are seeing certain trends in certain patients which will predict survival, and inflammatory markers are one of those which tend to predispose them to higher mortality. Next slide. So this is an important slide. What this slide is showing us is that what really, the real benefit you get from ECMO is avoiding ventilator. And that's the concept we came in with. And we proved that concept from what you're seeing in this slide. In patients who survived, the total ventilator days, the mean ventilator days were less than 9 days compared to 14 days in patients who did not survive. So despite ECMO, some of these patients stay on ventilator for a long time, and that is a very poor prognostic marker, and they tend to do very poorly. Another important variable which we picked up was number of vent days before we place them on ECMO. And this is a hypothesis, obviously. When we look at these patients, if someone is on ventilator for more than 3 days or 5 days, and if they're paralyzed, if they're hypotensive and a lot of pressors, and if their creatinine is getting worse, that patient obviously is not going to do well, is how we conclude from what we have seen in our experience here. And that's what is showing up in our statistical analysis too. If the days on vent before ECMO, before we place them on ECMO, if they're less than 3 days, the chance of that patient surviving seems to be higher compared to more than 3 days. Next slide. And this is a box plot analysis showing the same trend in a different manner. The vent days, less vent days before ECMO, total number of vent days on ECMO tends to predict survival. Next slide. Now, what gets better when you put a patient on ECMO? The obvious things are obvious, right? I mean, the PaO2 gets better. Pre-ECMO, if you look at the PaO2, it's 63. It gets better. That's what we expect from ECMO. The PF ratio is 64 in our patient population. Very sick patients, by the way. And the PF ratio does get better once we put them on ECMO. But remember, ECMO, all it's doing is providing oxygenation. We are not treating the underlying disease process. But what we are doing is we are avoiding ventilator-associated barotrauma. So as you see there, the PEEP, which stays high in some of these patients who are in severe hypoxic respiratory failure, gets better. The PEEP goes from 12 to 8 once we put them on ECMO, and most of these patients on ECMO get extubated within a few days. Next paragraph. Next slide. So this is the final slide. I'm going to end it here and take some questions if you all have any, but these are the VV ECMO outcomes so far. At Methodist, we have done 16 awake VV ECMO patients, 9 survived, 3 expired, 3 are still on ECMO. The average vent days after ECMO are 19 on non-ventilated patients, and on patients who are on ventilator prior to ECMO, only 11 survived and 15 expired. 10 are still on ECMO. So we all believe ECMO could be a strategy in avoiding ventilator-associated comorbid state and mortality. We are seeing this, seeing the trend here. It's hard to prove that concept without doing a randomized clinical trial, understand the limitations, but clearly by picking those high-risk patients and avoiding ventilator or quickly extubating them early might improve their survival. We believe, despite doing all this, even at this time, we are not 100% clear how to pick a patient to place on ECMO. And I'll open it up to Dr. Delavope and Dr. Kwan too, and they can add in more information here since they all have same experience. But we get calls, we get 10, 15 calls every day. We are accepting maybe one patient because we believe without data, ECMO may not help in majority of these patients if they're presenting late.
So can I make a couple comments, Chandra? When did you, this patient, and when are you using convalescent plasma and remdesivir?
Yeah, it's a very good question. Yeah, that's you know, when we started off this, it's interesting, Dr. Henry. Our first case in the Methodist, it was at MSTH, and Dr. Delavope can tell you more about this. The patient got plasma exchange and did well and went home. So we didn't know what to use when the patients came in initially. In March timeframe, we said we'll do plasma exchange. We didn't have remdesivir at the time. We were giving high-dose steroids. Now, as time went on, nowadays we are using convalescent plasma early on. The steroids and convalescent plasma are becoming initial treatment of choice. Same thing with remdesivir. So the treatment combination is either combination of steroids, convalescent plasma, and remdesivir. That's how we are dealing with right nowadays.
So let me just put out a thing right now. So that's, you know, first of all, I think when you get intubated, it's too late. And so what you should do is everything possible to prevent it. So if you have a positive troponin or even have a little hypoxia, on admission, we use convalescent plasma and remdesivir. And what's happened is early on we had, and you know, it's interesting because we have this mechanical circulatory support registry. And when I first talked to people in March with talking to the New Jersey and New York people, it was abysmal. Like all of the VV ECMOs and the rare VA ECMOs and the rare Impellas, like literally it was close to 100% mortality.
Right.
And that's not our experience at all. We had a very few number of VV ECMOs. We only had to do 6. All 6 lived. And second of all, once we got convalescent plasma, which was early in late March, we've had nobody that needed it. We use it early. We use it with remdesivir and with steroids. And we have not now, even though Ohio's had a bump, and it's not like Texas, and certainly you guys, it's a different group, and you have to be careful about this. But I would say this, right from when you walk in the door, aggressive early treatment has been really successful. It's been in the last 6 weeks, we've only intubated 1 person, and we've only had 1 death and during that time, and that was a person on hospice. It, you know, was going to die from cancer. So I would really encourage, I'm very convinced about convalescent plasma, whether that plus remdesivir, either one, and steroids, we do all 3. Because I think, and I'm sure, I suspect a lot of these patients actually came to you when they're already intubated, right?
Right.
Yeah, and that's what happened to us early on,
Right.
is that patients came when they were already intubated. And I would encourage everybody out there, treat early and prevent it. And then the next thing we just started doing in early mid-April is proning and doing everything possible not to intubate people. Because I think once you get intubated, it's a long haul. It's 2 or 3 weeks, even if you do survive.
Dr. Henry?
I think, yeah, that you rightly said it. You know, unfortunately, by the time we see these patients, like you said, they're already getting convalescent plasma, and that is the first line of therapy here, by the way. We give them dexamethasone 6 milligrams along with that, and remdesivir if they don't have renal failure. But you know, since we receive all these crash and burn, all these patients are on ventilator, high PEEPs, intubated 2 days ago, paralyzed, prone, can't come off Nimbex drips. What do you do with them? Like you said, I mean, you leave them on ventilators, they're going to go down. So we have used ECMO as an exit strategy. And despite that, because of the pathophysiology, our survival is 60%. So it's
not bad. But I mean, this is one of those things on the phone. People, I really think on walking into the hospital, a positive troponin, a high D-dimer, a high CRP, or early hypoxia, they represent a high-risk patient population.
Right.
And you'd be surprised. We've had so many people that came in with PO2s and 50, 60, you thought, oh, this is going to be terrible, who went home on day 3.
Right.
And I just really think early treatment, early aggressive treatment, and the 3 things, steroids, remdesivir, and convalescent plasma.
Okay,
so I don't know if
Mike Juan is online and wanting to add in some comments here. Mike, are you there?
Yeah, I am. Can you guys hear me?
We can hear you, can't see you.
Okay, yeah, my camera doesn't turn on. So I'm Dr. Kunavrapu's partner, and Dr. Della Volpe, you know, I think they've been doing an excellent job kind of putting this all together, and thank you for this presentation, Chandra. I'd agree with Dr. Henry. I think that the early intervention is really kind of the key and part of our patient population.
Oh, you just muted him. Sorry. Hold on, Mike, just 1 second. We accidentally muted you. Go to him over here.
Can you hear me now?
Yeah, you're back.
Okay, all right, sorry about that. I wanted to emphasize that, you know, I think the early treatment and the minimization of the fibrotic phase is really kind of the key. I think that we kind of have a referral bias, and we have a lot of patients who are transferred in after they failed earlier therapies at outside facilities. And although we run the convalescent plasma, a lot of our patients come in too late for the remdesivir. One of the things that we notice in our transplant population, it's way too early to say, is that although they're immunosuppressed, they seem more susceptible to the viremic stage. Few of them actually get the cytokine release phase or actually get into the fibrotic phase that our non-immunosuppressed patients do. So that may speak towards the idea that both Dr. Kunavarapu and Dr. Henry are speaking towards. Early intervention hopefully minimizes A, the cytokine release, and then B, the fibrotic phase. Although we've been applying ECMO, it's to minimize the barotrauma. So I think the key is really kind of acting early to minimize the damage that long-term therapies or long-term exposure to the cytokine release may lead to. And Chandra or Jeff, if you want to kind of add to that, I'll defer back to you guys.
Jeff, you want to say something?
We don't see Jeff online right now.
I don't see Jeff. Okay.
You know, the other thing is that I'll add to this for everybody, and you know what, Chandra, we should probably touch base later. Another interesting trial that is coming down the pike is for patients who are extubated but who are still hypoxic, because I think this is an issue. What do you do long term for people? There's a trial, companies called Caladrius, and they're using CD34 positive stem cells, which has been shown to improve patients with refractory angina, patients with microvascular angina. So it has the cells have a really strong effect on the microvasculature, and we think potentially has benefit in healing and in lung injury. So the right patient, and I suspect you have a lot of these people just from your numbers, and that is the patient who's off the ventilator and home, but still has long-term lung disease and is a little hypoxic. And so that might be something you're interested in, because I think we'd all, you know, the issue is not just getting people to survive, but not have long-term lung injury. And the right time might be to, you know, try that and put people in a trial for that. Because there's not too many, there's early treatments and there's ventilator treatments, but there's not too many post. I don't know of another trial that's post, so something to think about.
Well, speaking of that, we actually have a question from the audience here. And it says, even though there's a significant push for treating relatively mild symptomatic patients at home with monitoring, but do you think a panel of markers, including troponin and inflammatory markers, could be useful to predict the patient's clinical course and should be obtained in all patients with mild symptoms to triage the patient?
Absolutely.
Yeah, very good question. So we adapted a protocol for our transplant patients. In fact, Mike will speak to it too. We see a lot of our heart transplant patients. So how do you deal with a heart transplant patient who comes with COVID infection, right? I mean, you have to figure out a risk variable or composite risk variables to say, I'm going to be this aggressive or less. So you're absolutely right. We look at D-dimers, CRP, ferritin, LDH, you know, CRP, procal sometimes, and troponins, BNPs. And in my slides, I showed you BNP is an indicator of right heart failure, RV strain, or pulmonary hypertension, which we are commonly seeing again in these end stage fibrotic or COVID pneumonia patients. That's a different manifestation.
And you know, I'll make another comment about that. You know, early on, ACC website actually, this was in mid-March, and it recommended people not measure troponin. And it was like it totally misled everybody. The issue is not, oh, you have a positive troponin, you need a cath. The point was, like for the question, the patient with mild symptoms who comes to the emergency department, the troponin is an absolute strong predictor of who's going to do poorly. And so if you have a positive troponin, that tells me that patient should be admitted, number one. And I think there's pretty clear guidelines for hypoxia as well. And I think for D-dimer would be another one that would push me. But and then that's the group, that's the time to treat them, is first day in the hospital. In fact, my partner, Dean Kariakis, that many of you know, Dean has a new measure for COVID and that it's door to plasma. And, you know, he feels like the high-risk people, the faster you can treat people with convalescent plasma, that the better that they're going to do. Everybody doesn't need it. So I am absolutely not a mild symptoms with a normal troponin and no hypoxia. They don't need it. Most of them are going to be just absolutely fine. But the troponin and the hypoxia early on help predict who is not doing well.
We have another question from the audience here. In a COVID positive patient with no respiratory failure but elevated troponin, is there a consensus to discharge the patient on anticoagulation, and for how long? Also, what has the panel thought about the incident PE in this patient population and mortality?
I can tell you what we do at our place. Is it troponin or D-dimer? What is the question?
Yes, elevated troponin.
Troponin, no. You know, when they come to ICU and if the D-dimers are high, we are sending patients home on some type of anticoagulation. Eliquis is what our pulmonologists are using for a month or two. Since the pathophysiology involves microthrombotic process, but we haven't used just troponin as a guide to give put someone on anticoagulation.
I don't know that there's a consensus for sure. I think for thrombotic, you know, antithrombotic therapy, we've used D-dimer more, but anybody that gets hospitalized, we are using VT prophylaxis on everybody that gets hospitalized.
I'm going to throw one out there here because, as I told you this morning, Tim, is that, you know, I've seen on maximal anticoagulation in the cath lab in those last couple COVID STEMIs I've had, I just see clot happening. And do you have any advice for the group about how to deal with these patients? It's like they have this souped up Virchow's triad.
They do. And, you know, so I don't have the right answer for this, but again, I will encourage you. It's clearly a real syndrome. So you are not making this up. So there's this group of people that are very prothrombotic. Now, what do you do for that? So number one, we know that oral P2Y12 inhibition is suboptimal. So this is a group of people. So I have had two, but they weren't the super bad ones. But two people came that you could tell they were more thrombotic, and I used Cangalor, and it was effective. But I can tell you that Benita Shaw presented a couple cases where you're talking, we're very super thrombotic, right? Big, huge clot. And one of them was basically, you could tell normal coronaries. It was almost like it was, I mean, there's almost like no plaque in that thing. And she showed two cases where she gave intracoronary lytics and was successful. So I don't think we have the answer to this for sure, Jamil, but I think other than to know that if you see people that are prothrombotic right away, and others have gone with 2B3 inhibitors, you know, and then one of the issues, I just think personally mine would be what my algorithm just from listening to cases and watching them would be to start early use of Cangalor to get adequate antiplatelet. And then if I have trouble on top of that, the very severe thrombotic ones, I would use the intracoronary lytics. What's the right dose? You know, you can use either TNK or TPA. I don't think we know the right dose.
Okay, well, I appreciate that. It's nice to know that I'm not in the unknown about that. So we have another question coming in, and somebody's asking about the early treatment with hydroxychloroquine, azithromycin, and zinc and vitamin D3.
Here's what I'll tell you about it. First of all, everyone should stay away from the political parts of this. Like, that's crazy. When I look at the data overall over this, and just like you guys probably, many places used either hydroxychloroquine or chloroquine, I think that for the intubated patient or the really sick patient, it's not going to work. But I think that if it works, the benefit has been shown early. We have a trial where we're randomizing people that have exposure. So healthcare workers who have an exposure, we're randomizing them to hydrochloroquine versus not. It's too early to know. But you know, it's a therapy. It's been around for 25 years. I think it's safe. Whether it's effective or not, I think we don't know.
Okay. Are there any other questions from the group? Give it about a minute here. While we're doing this, I'm going to actually, Dr. Kunavarapu looks like he had to log off here, but I'm going to give Dr. Pollard and Dr. Henry kind of the final words here. What are the real take-home messages you want us to walk away with?
Go ahead, Tom.
Okay. Well, you know, first of all, I would just say that, you know, this is a disease that, you know, I took all the precautions. I was washing my hands, I was wearing a mask, doing all the things that you're supposed to do. But, you know, this disease can kind of pluck you out of that. And I think my case kind of illustrates that. Surprisingly, no one else on my operative team tested positive, even though I spent all day with them. My wife and son never you know, became positive, although I think we did a pretty good job with quarantine. So, you know, I just think, you know, certainly you got to take all the precautions that you can. You know, I certainly appreciate all the recommendations that everyone has made here. And, you know, hopefully we'll get through this. Hopefully a vaccine will be available soon because it's certainly affected all of us.
Chandra has popped back on. Chandra, you want to give your final comments, please?
No, I completely agree. I mean, it's such a, like I started off saying, it's a humble experience just seeing how patients can go down so quickly, young people. And it's very obvious. It affects certain populations and causes rapid deterioration. It seems like patients with diabetes who have poorly controlled diabetes, hypertension, obesity, abdominal obesity, poor functional status with history of asthma tends to make this pathology worse. Like Dr. Pollard rightly said, simple concept is isolation, precaution, and that message should go along as long as we can follow the social isolation. I think we'll be okay. And in terms of ECMO management, what I would say is we don't want to throw ECMO as a kitchen sink at the end. At the same time, we don't want to go too early too. So it's how do you avoid ventilator is a key concept here, is my feeling. And how do you decide when to go on is still a matter of discussion.
Great. Tim, the floor is yours.
Yeah, no, I think it's humbling. I think we've learned a lot already. And I think another really important thing is you can't get your health system get overloaded. You have, you know, and we get into trouble when we're overloaded, and you have to have adequate PPE. But it's humbling. And again, I'll go back to the best way to do that is if you guys have cases, really send them to us with the STEMI and thing, because we need to learn from it. It would be really helpful if we ended up with 300 or 400 COVID positive patients with ST elevation. We would have a much better idea. How often does this very prothrombotic case occur? What's the best treatment? Well, if I actually had, you know, a large number of patients in the trial, we'll be able to answer those questions. So support us.
All right. Well, I want to thank the presenters and the panelists, one and the same, for taking time out of their busy day and joining us for this meeting. This is really something that's taken the forefront, and really we're all struggling how to do it the best way. I would encourage everybody that with the San Antonio Interventional Forum and our Twitter page and all the share cases, tell us what you're thinking, ask questions. There is a plethora of expert interventional cardiologists out there who are all in the same boat. Guys like Tim, they pick up their phone, I can tell you that. They answer their emails, and call the guys who mentored you and see what they're doing. We're gonna get through it eventually, but again, I thank everybody for taking time tonight to talk, and I hope you all have a good night.
Thanks, everybody.
Thank you.
Thank you.
How do I stop broadcasting? Where's end? Right there.